All right. Well, again, thank you very much. And I sort of see my role today as sort of setting the stage for what looks like a very exciting session all day today. And just to sort of look back of where we've come from and where we need to be going. To anyone whose work I don't mention, I apologize. It was only 30 minutes, and it's going to be tough to cover all of what's happened in the past 80 years with radioactive iodine theranostics. But I do want to sort of set the stage and finish by sort of setting some of the challenges that we still face. So let's just start with just talking about something that we're all, I think, quite familiar with, which is the increasing incidence of papillary thyroid cancer. This is data from the United States, the SEER program. And it was actually, now the data itself is 10 years old, but it's still valid as this slope continues to go up, which is that in this 35 years here, from 1973 to 2009, the incidence of papillary thyroid cancer increased almost threefold in the United States. And this was in all ages, a bit more in older folks, but it was in all ages that we see this increase with no decrease in no increase in mortality. So we can see here down at the bottom, despite this increasing incidence and therefore prevalence of papillary thyroid cancer, the mortality rate really stayed pretty flat through that whole period. So when this happened, I think the original thoughts were, well, we're just finding it more. We have all this extra imaging. We have incidental thyroid nodules that we're discovering. People are getting more health care. There's more awareness of the need to treat thyroid cancer. But in fact, if you go back and look at the data, it's not clear that's really what's going on, because other forms of thyroid cancer, papillary, or rather follicular thyroid cancer, for instance, is not seeing the same curve. And so if that's not happening, it makes it seem unlikely that that's just an issue of detection. The other is, it's not only that the increase is of small, potentially subclinical cancers, but in fact, some of them are actually large. So that the number of large, greater than 4 centimeter cancers and disease with distant disease also increased. So it's not clear the underlying cause. It may be multifactorial, but what it does mean is that those of us in the clinic are seeing more patients with thyroid cancer, and it behooves us even more to have a harmonized approach and hope that we're providing the best care we can to our patients. Now, let's go back a bit. The first radioactive iodine therapy for any thyroid disease was in March of 1941. In fact, we're coming close to the anniversary here. Here we are in a couple of weeks. And that was Saul Hertz and Arthur Roberts, who were treating benign thyroid disease. They got their radioactive iodine from the cyclotron over at the Mass General. And then they helped the folks down in Montefiore. It wasn't like they were the only group thinking about this. There were groups across the country thinking about using iodine to study and to treat thyroid disease. And when Dr. Seidlin, Seymour Seidlin, and his group had a patient with metastatic thyroid cancer in 1943, they used radioactive iodine also from the Mass General cyclotron to treat that patient. Now, that patient was somewhat interesting and unique, or not quite unique, that's an overused word, but it was unusual in that he had functional metastases, right? And those of you treating thyroid cancer know that that rarely happens. It can happen, but it's not a common finding. And so that, I think, is really sort of what stimulated them to think, hey, we can use radioactive iodine. Well, as we know now, that's not a prerequisite for the use of radioactive iodine, and many non-functional thyroid cancers that take up iodine but don't make thyroid hormone can also be treated with radioactive iodine. So they published this in JAMA in 1946, but this was not only big news in the scientific literature, but also in the popular literature. This was from an article in Life magazine, and showing this poor first patient here, Bernard, looked pretty emaciated with his metastatic cancer and hyperthyroidism. And with therapy, he sort of looks pretty healthy here a couple of years later. And he actually, after this article, lived for another 6 years. So clearly had a response, a clinical response, and probably a prolonged lifespan as a result of his therapy for the first therapy. Now, this was also, the use of radioactive iodine was also stimulated because around the same time, the Manhattan Project was trying to broaden its mandate and was looking for civilian uses for radioactive isotopes. It started to distribute radioactive isotopes, including I-131, for use, for civilian use, with a focus on clinical care and medical research. And this was the report, the announcement in Science in June of '46, announcing that radioisotopes would be available from the reactor in Oak Ridge. And this, of course, they later became part of the Atomic Energy Commission, and was really what stimulated the growth of nuclear medicine, was having these readily available radioisotopes that did not require an institution to have their own cyclotron. So by 1960, radioactive iodine had been used in a number of places, and there were 8 reported series of thyroid cancer patients who've been treated with radioactive iodine. Now, only in each of these sites, only a small fraction of the patients had received I-131. In fact, not all of them even had a thyroidectomy. But this was early, let's just say this was early in the clinical use of radioactive iodine, and everyone sort of approached it differently. There were variable ways of staging, and as Dr. Blad, one of the authors of these series, said, there was sort of random and inconsistent use of adjuvant therapy, which meant everyone's doing it differently. And there was somewhat limited follow-up, right? Most patients, remember, this was only 14 years after most places had access to radioactive iodine at most. Most of the follow-up was 3 years or less. And of the patients with distant metastases, 1/3 of them had died by the time most of these reports had come out. Now, Dr. Blad and his group at the Los Angeles VA had 63 patients they treated for thyroid cancer during this period. Of that, 31 received postoperative I-131 therapy, although they were only able to follow up 26 of those. So it's interesting to read some of these reports, because they prepared their patients for I-131 therapy by hormone withdrawal, making sense, taking them off thyroid hormone replacement or suppression for 3 or 4 weeks. But interestingly, they also treated with TSH. Now, this, of course, is not recombinant TSH. This was extracted TSH. But it's interesting, this sort of sages what's going to happen in 30 years or so with the discussion of whether to use recombinant TSH or hormone withdrawal. They did a pre-therapy thyroid scan and then treated with 100 millicuries per administration, and every few months would repeat the therapy until either the scan was negative or the patient had been treated 4 times. They did post-therapy scans, and then they treated patients with thyroid hormone replacement to tolerance, also telling us the state of endocrinology practice prior to the availability of thyroid hormone assays. Now, this is interesting because it shows not only were the thyroid hormone assays somewhat primitive, this shows us the scans that they were able to do at that point. And you can see here, this is pre-surgery. This was an I-131 scan. Here we can see 2 lobes of the thyroid. One can imagine that maybe this has relatively decreased uptake because part of it represents a cancer. And then post-surgery, we have a wider field of view. We still here in the left neck have a region of increased radioiodine uptake, telling us that there's either remnant thyroid or remnant disease in the neck. So they had follow-up for up to 9 years, averaging 3 to 5 years. Now, the data that they give tells us that 10 of 15 patients with metastases had positive pre-therapy scans, and 10 of 15 patients with metastases were still living at the time of the report. It's not clear that these 10 patients and these 10 patients are the same. They don't share that. And then of 11 patients without metastases, all 11 were still living at the time of the report. So again, demonstrating a probable role, although, again, just sort of a retrospective review of patients being treated with I-131 and presumably showing some benefit. Now, if we jump ahead a few more decades, other groups started to report larger series of patients being treated with radioactive iodine. Two of the bigger series were from Mazzaferri. He was at Ohio State University and also collaborated with the U.S. Air Force, and so had patients throughout the Air Force health system. And then Dr. Hay at the Mayo Clinic also reported a large series. This, in summary, was a few years later, but they had intermittent reports throughout the 80s and 90s. And what we can see here are a couple of things that are interesting. These are, for the most part, patients just as they came. Now, as we dig in, we'll realize that Mazzaferri's group was using some radioactive iodine, although early on they did not use it extensively. The folks at the Mayo Clinic rarely used radioactive iodine. Despite that, their mortality was similar in the two groups. And this is all comers, all stages of disease, was probably somewhere between 6 and 8% for both groups. What they did have was a difference in recurrence, and that was the Mayo Clinic recurrence was about half that of the Mazzaferri group. And one can surmise a number of reasons. One is the Mayo Clinic folks had meticulous surgical technique and were proud of how they approached the surgery. The Mazzaferri group, on the other hand, they were getting patients from all over, multiple Air Force sites, and as well as local referrals. And so many times the original thyroid surgery was done by someone who was not part of their group. And so that right there suggests that a surgical approach may have something to do with recurrence. That said, these are tough studies, right? I mean, these were the retrospective studies had many limitations. There was mixed clinical disease. They included papillary follicular disease. Tumor size and the extent of metastases were completely mixed and lumped together. There was varying clinical practice, both over site as well as over time, right? Over the time that they were collecting these patients, the standard practice changed, particularly with Mazzaferri's group, as they used more and more radioactive iodine. And so the frequency, the administered activity, the timing of I-131 changed. The extent of surgery depended upon site. As we said, Dr. Blad pointed out, there was random and inconsistent use of adjuvant forms of therapy. And through those decades, other imaging became available, right? We had true scintigraphy and ultrasonography became available, making one think that by the end of that, the period of which they were acquiring patients for their registry, that more patients were, that other sites of disease were more easily found than they would have been found early in the collection period. And then there was selection bias, right? The extent of disease and the extent of surgery led the clinicians to decide whether a patient would get I-131, making it clear that there was a need for long-term, that is decades of follow-up, both for research as well as for clinical activity. Now, Mazzaferri, in fact, did do some of this, right? He did a 30-year follow-up of patients without distant metastases. So these were patients who had either soft tissue extension in the neck or who had lymph nodes but did not have distant metastases. And through the years, they had used different types of therapy. Some had even gotten external beam radiation therapy. They had a very high rate of recurrence and a quite high incidence of death. Compare this to no medical therapy, so that even no therapy was better than external beam radiation, but was still a pretty high recurrence and death rate. Thyroid suppression was better, and then patients treated with I-131 had the lowest rate of recurrence and the lowest rate of death, about 3%. Now, there was some bias in this, right? Because the patients who did not get medical therapy frequently were those who were less likely to have either extra-thyroidal disease, less likely to be follicular. Those patients were more likely to get some other therapy. So there was some bias, and one would think because of that, the no medical therapy group would do better. But in fact, even the, quote, higher risk patients treated with I-131 or thyroid hormone suppression still did better than no medical therapy in this series. Now, he also then separated out and said, well, we've got a lot of low-risk patients. What if we separate out and just look at patients who have either extra-thyroidal extension or cervical lymph nodes and look at either recurrence or death with I-131 or without I-131 therapy? And you can see here there was still a very significant difference, right? This is the recurrence with I-131 therapy was around 8% in this group of patients, while it was nearly 40% without I-131. And similarly, the rate of death was very different, with a very, very low rate of mortality, up to 35 years of some patients being followed after therapy, compared to, again, about that 8% that we've seen in some of their other reports. So these studies all were suggestive, all were more than suggestive, really supported the idea that for these patients who had a large spectrum of intermediate risk, that those patients truly benefited from I-131 therapy, whether you wanted to call it ablation or adjuvant therapy, they were benefiting from this therapy. Another group was the group in Chicago led by Leslie DeGroot. And here again, you can see that the probability of disease-free survival was much better with I-131 therapy, with a very low mortality or survival or high survival rate, low mortality, compared to patients who had no I-131 therapy. Now his study was smaller, right? It was a single site retrospective review, 269 patients, but a mean follow-up up to 12 years, and with a lower dose, right? Their I-131 ablation dose was 28 to 75 millicuries, smaller than what some of the other sites were using. And they were able, but with this, they were able to show that there's a decreased risk of major recurrence if the primary tumor was bigger than a centimeter, and a decreased risk of death for tumors bigger than a centimeter in those patients who had intrathyroidal or lymph node mets. But there was no apparent benefit for tumors less than a centimeter or in young patients less than age 45. Now, they also went back and looked at other factors, and the other factor which contributed to decreased death and recurrence was the extent of surgery. An extensive bilateral surgery, and there were, as you can imagine, various combinations that counted as this, but for instance, a subtotal lobectomy and then a lobectomy, or a subtotal thyroidectomy, and various other combinations counted as extensive surgery. But patients who they judged to have extensive surgery and a decreased risk of death if they had a tumor larger than a centimeter, and a decreased risk of recurrence for tumors of all sizes. Now, let's go to another point of view, and that's going back to the Mayo Clinic. They had published a couple of reviews. Now, one of their first reviews actually was back in the 50s, and they went and looked at their first 30 years of experience of treating thyroid cancer, clearly the pre-radioiodine era. And their rate of thyroid cancer deaths was a little over 6%. And interestingly, if the primary was less than 1.5 centimeters, they had no recorded thyroid cancer deaths in this 30-year period of over 500 patients. And they, although in a very specific way, but tumor grade also predicted the risk of death. So they then went back and compared another cohort. Now there's some overlap here, as you can see, but here was it from 46 to 70. So one might say this was during the radioiodine era. They had 859 patients with follow-up almost to 40 years. But interestingly, at the Mayo Clinic, only 3% of the patients received I-131 therapy. Very few received. Most of those were patients with distant metastases. They did have a couple of, their overall death rate was similar, 6.5%. And they interestingly had 4 patients with a primary less than 1.5 centimeters die, compared to the first 30 years where they didn't. Now, their take on this was their cancer death rate specific to thyroid cancer, or in thyroid cancer patients, was 6.5%, compared to the age expected death rate of 3%. So they said, well, only 3.5% belong to thyroid cancer. So probably not the way that we would do it now. But their I think overall conclusion at that time was that the use of radioiodine should be an unusual and not a usual therapy. Now, I think in some subsequent years that sort of changed even in the Mayo Clinic, but it did show that there was some data, and that with very good surgery, that many of these patients were going to do well. And it really falls upon the field as a whole to then decide which of the patients that really do benefit the most from radioactive iodine. Now, just to talk about one more large series of patients. This is from MD Anderson in Houston, And they also looked at the effect of therapy on outcome of differentiated thyroid cancer. And what they looked at is what both the sort of prognostic features of the patient, both patient characteristics and therapy, and looked at whether that was related to a decreased or increased relative risk of recurrence. Not surprising now, as we have had more experience with thyroid cancer, female gender and age less than 40 years were both associated with a decreased risk of recurrence. Intrathyroidal disease and papillary thyroid cancer, both also with a decreased risk. A total thyroidectomy and treatment with I-131. So each of these alone was a predictor of a decreased rate of risk of recurrence, while the opposite, male, older, with soft tissue extension, with follicular hurdle cell pathology, less complete surgery, or no I-131, each was associated with an increased risk of recurrence. Now, they did a follow-up of a median of 11 years, a maximum of 43 years. So again, as time goes on, we're getting longer periods of follow-up. And they also noted, which I think many of us would agree from clinical experience, that the highest rate of death was in the first 5 years of follow-up. So in fact, they also didn't look just at recurrence, but also looked at death. You can see here these sort of tables sort of mirror each other. What is added is, with the extent of disease, lymph node disease was somewhat there in between intrathyroidal disease, just disease within the thyroid and soft tissue extension. But clearly, when evaluated for a predictor of mortality, lymph nodes predicted a decreased risk of death. And so they were similar to actually to intrathyroidal disease, going with what we're used to seeing. And then distant metastases were associated with increased risk of death. So at this point, here we are, at that point, we were sort of in the late 20th century. It was clear that the treatment of thyroid cancer, the primary therapy was surgery. We knew that ineffective therapies were adjuvant chemotherapy or external beam radiation, while effective therapies included surgical re-exploration, TSH suppression, and radioiodine therapy. So it still wasn't clear the details of what was the appropriate management. We did have sort of this now general consensus. But as we all know, this was evolving with the turn of the new century. So the benefits, I think, if we sort of summarize, is I-131 increases recurrence-free survival, probably increases overall survival. Its greatest benefit is for tumors greater than a centimeter, and greatest benefit is for patients with extra-thyroidal disease. That's not saying other patients don't benefit, but these are the groups that have the most. How about tumors less than a centimeter? That's tougher to show because the numbers are tough. When the recurrence rate or death rate is low, it takes a very large study to show if there's any benefit. And similar, extra-thyroidal neck disease may be the biggest benefit, but clearly patients with metastatic disease also have some benefit. And it was used for 3 indications. These were not as formalized as they are now, but there was the thought of ablating the thyroid remnant so we could do follow-up with thyroglobulin. Post-surgical adjuvant therapy, patients who had resected neck disease and presumably had no disease at the time, and then treatment of known metastatic disease, particularly lungs and bone. Now, we're going to hear from Dr. Van Nostrand later today. Back in 2007, he and Dr. Wertowski published a review article talking about treatment of metastatic thyroid cancer. And they had 6 groups here who had different ways of treating. Now, the details here aren't important, except to recognize that each of these large groups had a completely different approach. I mean, the overall was similar, big doses of radioactive iodine, but the details of how it was administered different between all these sites. And I think the take-home message is that although we spend a lot of time talking about intermediate risk, we have even less data on what the appropriate approach is for treating patients with distant metastases. So in 2004, Dr. Leidenson at Johns Hopkins wrote a review article talking about the controversies as of 2004. And I think we'll recognize this list, and this list is probably still sort of current, right? Staging and risk stratification, the extent of surgery, what to do about small tumors, well, how to manage remnant ablation, post-surgical imaging, pre-therapy preparation, withdrawal versus recombinant TSH, follow-up surveillance, the role of PET scans, both FDG as well as thyroid-specific imaging, should we be doing dosimetry, and how do we manage iodine-resistant disease? This was 2004. I think this list is, with a few exceptions, is probably current, and we still are dealing with many of these issues. Now, remnant ablation is there's almost always a small amount of remnant thyroid after surgery. So the goal is to ablate that small bit of normal thyroid to facilitate post-therapy management. So we can do post-therapy scanning, we can use thyroglobulin, as we'll hear later today. And there's this question about treating microscopic disease. And that, of course, is where we got in trouble in the past, because people would be trying to ablate, but maybe they'd want to sort of treat some microscopic disease. And so it became sort of unclear what the appropriate administered activity should be. You know, people had used, investigators and clinicians had used up to 100 millicuries. And I think more the standard is 30 millicuries. And we'll talk a little about that. This was a sort of there had been much literature both on the use of recombinant TSH as opposed to thyroid hormone withdrawal, and also the question about what the right administered activity. So this nice study from France published in 2012 did a very good job of doing a sort of a randomized prospective enrollment of patients and assessed ablation using either whole body scan, ultrasound, or thyroglobulin. And what the short answer is whether they use recombinant TSH or thyroid hormone withdrawal, whether they use 30 millicuries or 100 millicuries of radioiodine, the results were the same. They got a very high rate of complete ablation of thyroid tissue, suggesting that we might just as well use the smaller dose if we can accomplish the same goal in patients. And recombinant TSH is easier for patients to deal with. And so this, I think, sort of provided many centers that had been sort of slow on adopting some of these new approaches. This, I think, provided the stimulus for them to do so. Now, in the interim, we've had a couple of advances. The pre-therapy scans originally had been performed with I-131, and through the the late 90s and early 2000s, there was more and more evidence from numerous groups that I-123 scans might be preferable. This is the group from Penn. We can see I-123 scans compared to the I-131. It was a balance between the superior imaging characteristics of I-123 and the physiologic and physical benefits. The fact that the I-131 was going to predict the kinetics of the treatment dose, I think that made the I-131 particularly preferable to many people. But over time, I think, at least until recently, I-123 has sort of won out because of the better imaging characteristics, as well as something that's talked about a lot less now, but at the time was the concern for potential stunning with I-131. So pre-therapy whole body scan, as I said, I-123 appears to be preferable to 131, remembering that there is an altered biodistribution, right? It's not the same biodistribution we see after 2 or 3 days of I-131. It allows us to characterize the remaining thyroid tissue. Is there a large thyroid remnant? I know some centers will actually treat the remnant with an ablation dose prior to even doing an adjuvant or treatment of distant mets, so that they don't have a large uptake within the remnant, but also allows us to find additional local, regional, and distant metastases we may not have been known. And that allows us then to change the treatment plan, either additional surgery or possibly a change in the I-131 dose. Another question that has been part of the field for many decades is whether dosimetry is necessary. These are dosimetry images. You can see the flask with the standard in the image. We know that the critical organs are marrow and sites of metastatic disease, and we want to avoid marrow suppression, and particularly pulmonary fibrosis, as well as injury to tissues adjacent to any other sites of metastases. So it seems on a clinical basis, the dosimetry right now may be most valuable in patients with lung mets. One of the things that sort of holds this back is that most of the time we need a medical physics consultation to do this well, and not all clinicians have easy access to a medical physicist. So it remains unclear what the appropriate role of dosimetry is going to be. We're going to hear more about that, I think, today. And I think what we'll find is as dosimetry becomes more accepted for other radiopharmaceutical therapies, we may find ourselves doing more for thyroid cancer also. This was a patient of mine, a 14-year-old girl with metastatic papillary thyroid cancer. These are her post-therapy scans. This was after the first therapy. You can see extensive lung disease, which then took up a huge amount of radioactive iodine. She had persistent disease, got a second treatment. And although the chest x-ray looks as if anything, the disease is worse, there's less uptake. And the question would be, does this tell us that this is fibrosis, or is this disease that's no longer taking up radioactive iodine? And an FDG PET helped us answer that, because we see that there's substantial disease that's FDG avid, suggesting that we have non-radioactive iodine or non-iodine avid or refractory disease. So the challenges and next steps, we still need to sort out what the appropriate surgical approach is. How are we going to risk stratify patients, both clinical staging as well as pre-therapy imaging? And what's added to this in the last 20 years is the availability of molecular genetic characterization. And I think this is a challenge to the whole field, and we're going to hear more from Dr. Gulick about this, about how to incorporate this into our risk stratification. And then how are we going to do risk-based I-131 therapy? What's the role of dosimetry and advanced imaging? How do we prepare the patient and use adjunctive therapies? And what do we do about iodine refractory disease? Now, in 2016, the ATA came out with their most recent recommendations regarding management of thyroid nodules and thyroid cancer. And this, I think, sort of brought things to a head, recognizing that there was no longer a real consensus within the field of people who studied and treated thyroid cancer. I think with low-risk disease, tiny primary, there was some sense that maybe radioiodine wouldn't be necessary. And clearly, patients with extensive disease or distant metastases should be treated. But it was this intermediate group. And I think here, we still have yet to completely decide how to stratify patients, what characteristics are important for stratification, and then once we stratify them, what's the appropriate therapy. So this has led to a group of societies, the ATA, ENMA, ETA, and SNMMI have gotten together to sort of lead interspecialty collaboration and consensus. This was their first report. You can see the authors here, published in 2019. And on this, they came up with what's known as the Martinique Principles that many of us are familiar with. I think the most important part of this was they provided standardized definitions of remnant ablation, adjuvant treatment, and treatment of known disease. And I think the other thing that was important is they recognized that advancing thyroid cancer management requires a commitment to interdisciplinary cooperation, and that we're going to need more studies. So we're back to this same list, recognizing that we're going to have multidisciplinary collaboration in clinical care, in clinical investigation, and clinical practice guidelines if we're going to take the field to the next step. And then finally, just for something for people to think about while we're listening to the talks today, you know, a lot of people in this field, myself included, have developed strong opinions through the years. And I think it's important for all of us to remember that, as Thucydides said back 2,500 years ago, it's the habit of mankind to entrust to careless hope what they long for and use sovereign reason to thrust aside what they not fancy. So in other words, keep an open mind. And I think that'll serve us all well as we hear what looks to be a series of very good lectures for the rest of the day. Thank you for your attention.